Greetings to those of you who are just joining us. We're going to give folks a couple of minutes to get logged on, so just hang tight for the time being. Elizar, somehow it's switched so that instead of seeing it, the thing is full screen, it's like just a little tiny. No, just a little tiny. There we go. Thank you. Welcome to those of you who are just joining us. We're going to give folks a couple of minutes to get logged on, and then we'll go ahead and get started. Welcome to those of you who are just joining us. We're going to give folks maybe another minute or so to get logged on, and then we'll go ahead and get started. All righty, we have a lot to get through today, so I think I'm going to go ahead and get started. Hi, everyone. My name is Hilary Godwin, and I have the honor of serving as Dean of the University of Washington School of Public Health. We know that many of you have questions about the start of the term, even after reading all of the gazillions of emails that have gone out centrally and locally. So we wanted to provide an opportunity to have a more nuanced conversation and hopefully answer some of your questions. For those of you who have not previously joined us for one of these webinars, I wanted to let you know that, as you see on your screen, we use the Q&A function for asking questions, and we use the chat function to provide links and resources. So if you have a question, please use Q&A and as opposed to, say, raising your hand. I also wanted to point out, because we have people who are from outside the School of Public Health joining us, that some of the guidance that we will be talking about today may be specific to the SPH community as opposed to the UW as a whole. So I will try to be clear, and Carrie will try to be clear when that's the case. But if you have a primary appointment in another unit on campus or primary position outside the University of Washington, please reach out to your dean or your supervisor if you have questions or want more information. I want to start by acknowledging that this has been a long 2 years, and that many members of our community have suffered greatly and experienced just tremendous losses. Our hearts go out to all of you who have lost loved ones and friends. And our thanks go to the healthcare community, to a couple of whom are represented here today, and also our public health practice partners who have done so much to keep our community safe and healthy during these difficult times. I also want to acknowledge that all of the changes and ongoing uncertainties associated with the pandemic are hard on everybody, and the decisions that we have to make institutionally are challenging in that there are often no good solutions to the situations we face. I've really appreciated all the feedback that we've received from staff, from students, from faculty, particularly in the fall, as we transition to working predominantly in person and teaching predominantly in person, and wanted to reassure you that we take that feedback seriously, and have done our best to incorporate it into our ongoing guidance for SPH, and have tried to provide greater flexibility where possible in response to those requests. I'm really delighted to have joining me here today Tim Dellit, who is the Chief Medical Officer for UW Medicine and also Professor of Medicine and Infectious Diseases. Anna Wald, who is the head of Allergy and Infectious, the Allergy and Infectious Diseases Division in UW Medicine. She's a professor of medicine, laboratory medicine and pathology, and epidemiology in the School of Public Health. And last but not least, Carrie Farquhar, who's our Vice Dean for Education in SPH, and also a practicing infectious disease doc and a professor in global health medicine and epidemiology. So I'm going to provide an overview of sort of where we are. After that, I'm going to invite Tim, Anna, and Carrie to provide insights into what we're seeing in the UW medical system. From Tim, from Anna, some highlights of new research studies coming out on COVID and particularly on the Omicron variant. And then Carrie's going to talk a little bit about instructional guidance and some of the nuances of that for members of the SPH community. And then we'll open it up to questions from the Q&A box. Before we launch into that, though, I would like to acknowledge that even though we are gathering via Zoom, we're doing so on Indigenous lands. And I, in particular, want to thank one of our SPH staff, Tess Matsukawa, who wrote and shared with me the version of the land and labor acknowledgement that I'm going to use today. So today I'm calling in from the Indigenous lands of the Suquamish people. In Seattle, where many of us live and work, we also acknowledge all of the Coast Salish peoples of this land, the land which touches the shared waters and tribes of bands within the Suquamish, Tulalip, and Muckleshoot nations. This land was stolen by European colonizers. It was stolen from the Duwamish, who are still here and continue to honor and bring light to their ancestral heritage. Likewise, this country was built on stolen land with the exploited labor of enslaved African peoples, as well as the exploited labors of Asian and Latinx peoples. These acts of colonialism, white supremacy, and anti-Blackness are the history of this country, as well as our ongoing and current reality. We want to honor and recognize the lives, knowledge, and labor of Black and Native peoples in the past, present, and future. Within public health, there's an immense need for action that's centered on the liberation of Black and Indigenous peoples. This requires an understanding of the context of where we are, our positionality within those systems, and a dedication to justice-based actions. Wherever you are tuning in from, I hope that you will join us in honoring with gratitude and respect the Indigenous and Black and Brown people who are the original keepers and caretakers of these lands. As members of the public health community, we commit to being better stewards of the land we inhabit and partnering with Black and Indigenous communities and other communities of color to implement the health, to improve the health of all people. And I wanted to point out that if you're looking for a particular way to honor and learn more about Indigenous wisdom, we have an amazing health sciences common book this year that is called Braiding Sweetgrass, which was written by Robin Wall Kimmerer. And her prose is so beautiful. I just have to say there are many times over the last couple of months when I've turned to reading her work, and it's almost like engaging in a reading meditation. So I highly recommend that if you haven't picked it up yet. It's a good healing thing to turn to in difficult times. And because there has been a lot of depressing news lately, I thought I would start with a little good news. We're seeing evidence from South Africa that suggests that the Omicron wave came down there very quickly, just as it went up very quickly, and as we're seeing a big, quick uptick here. Also, results from South Africa suggest that patients hospitalized from Omicron have tended to be younger and healthier and required less intensive treatment than those hospitalized in prior waves. And we're starting to see new studies, both in people and in model systems, that suggest that Omicron causes less severe disease, in part because it stays in the upper respiratory tract more than prior variants. So it's just a little window into some of the good news and latest research. I know we're going to hear more from Anna later. In terms of case counts and other COVID statistics, I'm sure you are all aware that COVID cases both nationally and locally continue to rise sharply, with Omicron being the dominant strain in King County for the last couple of weeks. A combination of workforce shortages due to COVID-19 and winter weather has resulted in large numbers of flight cancellations, both nationally and locally. And what we're seeing here in the UW community is a significant uptick in cases this week as a result of folks in our community returning to campus and doing what we want them to do, which is to get tested. So as of today, there are 521 active cases of COVID-19 in the UW community. It's about double what it was last week. And a significant number of these cases are in individuals who are fully vaccinated and have received a COVID-19 booster. Public Health Seattle and King County reported today that they had over 4,000 new cases since yesterday, which is a 27% increase in cases in the last 7 days compared to the prior 7 days, which may sound like a lot, but is a less steep increase than what we've been seeing most days last week. So that actually is somewhat good news. And also King County reported 28 new COVID hospitalizations since yesterday, and a 51% increase in COVID hospitalizations compared to the prior 7 days. Husky testing program today is reporting just about an 11% positivity rate over the last 7 days. And UW Virology, which does testing throughout the county and community, actually was reporting a 27.6% sample positivity rate for yesterday. So I'm going to stop there in terms of those updates, but obviously we will look forward to hearing from Dr. Dalet about how the current Omicron wave is impacting UW Medicine and other area hospitals. Another thing that is complicating the situation are changes in COVID guidance, both nationally and locally. Last week, the CDC released new guidance about recommended isolation and quarantine periods, changing from 10 days recommended isolation to 5 days for individuals who are asymptomatic, and followed by 5 days of mask wearing, which with a bunch of caveats and also clarifications that came out last night. And they also updated the recommendations for quarantining to which again has a lot of if-then clauses in it, but to make it stricter than was previous for people who are not vaccinated. I want to point out the CDC has released separate guidance for quarantine and isolation for healthcare workers, and that we at UW are still waiting to hear back from Washington Department of Health and Public Health Seattle and King County about whether or not the new guidance that's not for healthcare workers will apply to higher education within the state of Washington. We currently are thinking probably it will, but there's a lot behind the scenes that needs to happen in order for UW's guidance to shift. So I would say expect to hear some news about that either later this week or early next week. But until further notice, please follow the current UW guidance that is laid out in the flow chart that is provided by UW EH&S. And I'm hoping that either Carrie or Shiva could maybe paste into the chat box for everyone the link to that guidance. So what does this mean for us operationally at UW? I assume all of you guys know that most classes are being held online for the first week of winter quarter. That was announced on December 21st by President Cauce and Provost Richards. And I want to highlight that this is different from prior instances where the entire university shifted to online instruction. It's different both because it is for such a limited period of time, and also because we were very clear that the university is remaining operational during that period. So the decision to delay in-person instruction for the week was an operational decision. It was based on knowing that people would be experiencing delays due to travel. We didn't anticipate how bad they were going to be because we didn't know about the additional weather issues. But that was not a surprise that there would be travel delays. And we also wanted people to be able to test and, if necessary, isolate and quarantine after returning from travel and not have to get back immediately into the classroom. So that was the reason for on the campus level, again, this is a campus level decision, the primary motivation for having that sort of 1 week buffer time that we would be having classes predominantly online. However, I want to emphasize that we still remain confident based upon what we saw from fall quarter, that using appropriate infection control measures, which people have been great about adhering to during the fall quarter, that we should be able to teach safely in person without having substantial transmission in the community. Obviously, if that were to change, if we were to start seeing transmission in classroom environments, then that would be a reason that the university wholesale would consider a shift. So what's different about this time versus when we had prior peaks or when we had prior shifts to online instruction? We are fundamentally in a different place than we were during those prior peaks. Right now, the majority of our community is vaccinated. As I said, we demonstrated during the fall quarter a really good ability to maintain in-person instruction without significant transmission on campus. In addition, so far, Omicron appears to be less virulent than previous variants. And although we are seeing breakthrough cases in individuals who are fully vaccinated and boosted, these cases are predominantly mild. So as a result, the university as a whole is prioritizing in-person instruction for this quarter, both because it makes sense pedagogically and also because we care about the mental health and well-being of our students. So we heard loud and clear from students across campus, not everybody, but a large number of students, that as difficult as fall quarter was, it was still preferable to online instruction. That being said, President Kelsey and Provost Richards clearly indicated in their message on Monday that they are providing considerable discretion to instructors to temporarily either continue to teach online, for instance, next week, or to shift to instruction online temporarily at a later point in the quarter if they need to do so to accommodate either large numbers of student absences, or if they themselves need to isolate or quarantine, or if something comes up like you have a kid who's in the school system and your kid has to quarantine and you have to be home for your kid. Now I'm going to get to some very specific to SPH, how we're interpreting that within SPH. So for instructors teaching classes within the School of Public Health who wish to temporarily extend or switch to online teaching, please work with your department chairs. You do not need to consult with us in the Office of the Dean for that. Conversely, if you wanted to teach the entire quarter online or wanted to maintain online instruction even after things have settled down and we're not having the same issues in terms of having a surge in cases, then you need to go through the standard processes for either getting accommodations from the Disability Services Office or special arrangements through the Office of the Dean. And the information about how to do that is provided in the guidance documents, which Carrie will provide a link to, that are posted up on our website. I also wanted to come back to this really critical point, which is that we are committed to maintaining essential services on campus, even during this week when everyone is away. So you see Carrie's in her office. That's because we've been rotating in the Office of the Dean, making sure that at least one responsible party is present in the Office of the Dean each day in case there's some situation where students need assistance, and to make sure that the building's functional and that we're able to provide basic services for students. That being said, we also recognize that not everyone needs to be on campus and in the office while our region is experiencing such high levels of COVID-19 transmission. Therefore, in SPH, and again, this is SPH specific, we've announced that we are providing increased flexibility for non-essential staff to work from home for the first 2 weeks of January. So regardless of whether or not you have an approved telework agreement in place, if you have a primary appointment in SPH and you are able to conduct your work from home and have permission from your supervisor, you are welcome to work from home during the period of January 3rd to 14th, 2022. We just want to point out that, as I mentioned, we're still maintaining this basic coverage. So it is possible that we may ask a limited number of staff to come into work on a rotating basis, just to ensure basic operations. The other thing that we're really asking specifically within SPH, and this is consistent with recommendations from Public Health Seattle and King County, is we're really asking that you limit workplace-related in-person gatherings for these first 2 weeks of January while we're still seeing this surge, unless they're for instructional purposes or play some critical operational role. Okay, so with that, I'm going to transition to our 3 guests and give them some time to give you some updates about what's going on within the area that they have visibility into, starting with Tim Dellit, who, as I mentioned, is the Chief Medical Officer for UW Medicine. Tim.
Great, thank you, Hilary, and thank you everyone for joining us here this afternoon. I was reflecting back, it's been just over a year ago that we started vaccination, and I don't think any of us thought we would be here at this moment, a year later, in the midst of what is really now our 6th surge. And each of these surges has had their own personality. And unfortunately, this one is also very unique in many ways. As Hilary mentioned, we have seen really an exponential rise in cases. If you think back when this pandemic began, we were only seeing 200 cases a day during that first wave. Now it had devastating impact because it landed in long-term care facilities. But now we're seeing upwards of 2,000 to 3,000 new cases a day. And as Hilary mentioned, just 4,000 the other day. So very high numbers. Because these numbers are so high, even though it does appear to have more mild symptoms, particularly those who are vaccinated and boosted, we are still seeing an increase now in hospitalizations as well. And so if you look at our system today, we are at 126 patients across our 4 hospital campuses. That is the highest we have been throughout this pandemic. Our previous high was 124 back in April of 2020 and December of 2020. And I anticipate this number will continue to rise. It's also interesting that historically within our system, about half of the patients in the hospital were in the ICU. While we're not seeing as many critically ill patients in terms of proportion, about 80% of these patients are actually on acute care floor. So they're not in the ICU requiring mechanical ventilation or other higher levels of care. Interestingly, many of those patients may have been admitted for other reasons. Maybe they were in a car accident. Maybe they had a broken bone and they happen to also be positive for COVID-19 just because it's so prevalent within our community. When you look at the other real change with this surge is the impact on our workforce. We have just over 600 employees that are out within our clinical environment, either because of infection, about 450, or 150 on quarantine because of exposure. We never saw that before with the previous waves. And so you take that combination of really limited bed capacity along with staffing challenges has put the hospitals really in extremis. And it's not just within our system, but across Western Washington. Eastern Washington, we are just starting to see hints in some areas of increase, but they're lagging right now. But we anticipate that their increase will be coming as well. We do hope that this is a shorter duration in terms of the upswing and then coming down. But I do anticipate that the month of January is going to be quite challenging, particularly within the healthcare environment. So what are we doing? Well, we're working through our surge plans. We have patients, unfortunately, in hallways and other spaces that we are creating to be able to safely care for them. Staffing is a real challenge, and we are shifting from what we refer to from conventional phase to contingency staffing, which means that the ratios in terms of the number of staff per patient is increased. Again, we still believe we can provide safe, high quality care, but it is a real stress on the system. We're also with that evaluating the isolation and quarantine duration. For healthcare workers, it's a little different. What we're doing within UW Medicine is if someone never had symptoms, we're testing them with an antigen on day 5. If they're negative, they can come back. If they ever had symptoms and they're improving, and if they're negative on day 7, then they can come back. If they're positive, then they wait for the full 10 days. We've had to, because of the bed capacity and staffing challenges, we have started to postpone non-urgent surgeries and procedures, particularly those that are impacted by staffing or bed availability. We're transitioning to more telemedicine visits. Recall throughout this pandemic, we went from only 200 telemedicine visits a month to over 30,000 in those early months, and we've continued to do 20 to 25,000 per month, and that number will go up now as we transition. You may have also seen announcements about leveling up your masking. And so within our hospitals, we are now requiring at Harborview the use of N95 or KN95 or KF94 for routine masking in place of a surgical mask. We're still using fit tested respirators for the care of patients in airborne precautions or aerosol generating procedures. The reason we've up leveled with our masking is both source control, because sometimes we may have, unfortunately, workers who come in with no symptoms, they just don't know they're infected. So decrease exposure to other colleagues, decrease exposure to patients, as well as to protect the healthcare workers themselves. UW Medical Center is strongly recommending the use of N95 or equivalent and are transitioning towards required. So we're both moving in that direction. We've also unfortunately seen testing constraints, right? Even though we all hope there were more antigens available, they're not. Antigen testing also has to be used in the right scenario because of the decreased sensitivity of those tests, particularly in people without symptoms. When you look at our testing sites, we've had decreased capacity because we can no longer pool the samples. When the positivity rate is over 10%, and now it's, as Hilary mentioned, 27% in our lab, what we used to do is we could take 6 samples, combine them all into one, test them once, and if they're all negative, all 6 are negative. If they're positive, we go back and test each one individually. But now that rate is so high in terms of positivity, we can't pool. So we have to test each sample individually. And so our testing capacity is still about 8 to 10,000 per day, but down from the 15 to 20,000 that it used to be. As Hilary mentioned, last thing I'll just say, we also are trying to decrease density within our environment. Now it's harder in the clinical arena, but in our other non-clinical areas of the school, certainly in office spaces, and we'll have conversations within the lab spaces as well, thinking about how do we decrease density and try to decrease that risk of exposure while masking up, as Hilary mentioned as well. So I'll pause there and wait to see if there are questions later. So thank you again, Hilary.
Yeah, thanks, Tim. As Tim mentioned, so we'll take questions all at the end. So I think at this point, we'll transition to Anna.
Thank you. And thank you very much for inviting me to join you. When Tim mentioned that each of these peaks has its own character, I had this vision of a toddler having a huge public temper tantrum. And we know that those end usually pretty quickly. So I'm hoping that this surge also will end pretty quickly. So this Omicron strain is a little bit different. It has more than 50 overall mutations from the ancestral strain, including 30 of them in the spike protein, which is what binds the human cells. It also is showing altered tropism. So its ability to bind is less for the cells in the lung and more for the cells in the upper respiratory tree, which is probably why it shows predominantly as an upper respiratory infection as opposed to pneumonia. There's some data that the yield actually may be better from saliva instead of nasal swabs. There was a study in South Africa on 380 people that showed that the yield was higher. So as we learn more about it, we may be switching actually to using more of saliva instead of nasal swabs. It replicates faster in the laboratory and it reaches a higher viral load, suggesting that it really is substantially more infectious than the prior variants. It also has a higher attack rate in the secondary household contacts. So for other strains, including Delta, the secondary attack rate was somewhere between 14 and 20%. For this one, it's 30 to 40%. So even when we know that somebody is infected in a household, the likelihood of transmission appears to be higher for Omicron than for the other strains. There's also a higher rate of asymptomatic carriage. For example, in the two studies that were just posted, one of them from South Africa showed that 16% of asymptomatic healthcare workers were positive when tested on routine surveillance testing. In another study that was looking to enroll participants into a COVID vaccine trial in South Africa, 30% of people presenting for enrollment who are asymptomatic were positive at screen. That's huge. That's 1 out of 3 people were positive. So it has really swept through that entire country, and I suspect through most of the African continent. One of the most interesting graphs that I saw, and I'm going to share this with you because I think it's so interesting, is this. Can you see it? This is the Boston poop study. And it is looking at the concentration of RNA for SARS-CoV-2 in sewage in Boston. It starts here in March of 2020. And you can see here the prior peaks, which are really not very high. And then suddenly you see this completely logarithmic rise in the amount of virus present in the sewage. And this is not limited to Boston, because the data from Nevada, from Los Angeles, are actually almost identical. Okay, so you can see that there's something biologically different about the way that this virus is spread, and potentially about the way it is excreted into the sewage system. Those were the 2 slides I wanted to share with you. The other important thing about this virus, that it's very clear that prior infection is not protective against acquiring it. I'll talk about vaccines in a minute, but the best data for that actually also comes from South Africa, because that continent and South Africa as a country has had very high rates of prior infections. In terms of the manifestations of Omicron, it is more like flu or cold. There's less loss of smell that's been reported. And consistently, again, both from South Africa, from Denmark, from Scotland, it's about 2/3 less hospitalizations with Omicron. But I did want to say that I think some of this is confounded both by age and also by prior infection status, which may modify the course of the disease, even if it doesn't protect. It's also important to note that monoclonal antibodies that we have been increasingly relying on for administration early on do not work, except for 2 of them that are not very available. So we have sort of less ability to use those tools. However, the antiviral drugs, including the newly approved ones, are all expected to work on this strain as well. It is clear from data from people who've been vaccinated that you need very high levels of neutralizing antibodies to SARS-CoV-2 to neutralize Omicron. So boosts are really essential. So if there's anybody listening who has not gotten boosted, or who has family members who have not, I think that's a very important message. After the boost, the estimates for effectiveness that I have seen against infection are about 40 to 70%. So it's a pretty wide range, and I think we're still getting more reliable data coming out. I also think we have to be careful when we talk about effectiveness of vaccines. Are we talking about death, hospitalization, symptomatic disease, infection? All of those are incredibly important for a variety of reasons, and we just need to be clear, what do we mean when we talk about vaccines being less effective? Now, one of the really interesting things that I also wanted to touch upon is, where did this come from? And there are several different theories about it. However, it's most likely that it came from someone who's immunocompromised, who developed a chronic infection in whom this virus was mutating over and over again, probably for many months, if not longer. It is clear when you look at the phylogeny that this virus actually originated very early in 2020. and it has sort of percolated along until it was able to take off. What does this mean? Well, I think it's a really important message here is that we need to focus on protecting immunocompromised persons to avoid new mutants. What are the reasons for immunocompromise? Probably when we look across the world, HIV is the most common reason, which means that we need to keep providing appropriate testing and therapy for HIV infection globally. And this, I think, highlights the need to talk about equity in terms of both access to COVID vaccines, but also access to other medical care, such as HIV testing and ART across the globe if we are to avoid emergence of new strains. And lastly, I just wanted to thank our colleagues from South Africa for developing the infrastructure and the readiness to be able to pick up this Omicron strain in a record time. And I think I'll stop here. Happy to take questions.
Great. I am seeing lots of questions come up, but I'm going to switch to Carrie and then we'll come back to the questions. Carrie, go ahead.
Great. Yeah, thanks, Hilary. And thank you, Tim and Anna. Really fascinating, interesting data. I don't have anything quite that scintillating, but do want to kind of share some guidance that's specific to the School of Public Health around teaching. And this is really directed at those of you who are teaching this winter quarter. Just to reiterate that it's per University of Washington leadership that instruction is going to be synchronous and remote this week. And then there's the flexibility next week to teach remotely, as well as in future weeks as needed, given the different situations that we anticipate will arise. For the School of Public Health, though, what we're doing that's different from the university as a whole is asking, strongly encouraging all of you who are teaching to record and then post your presentations on Canvas. And I say whenever that's possible, because we do realize that some classes are not amenable to that, and you won't be able to do it on every occasion. And what we've provided at the school level is access to 2 teaching assistants, Megan and Jeffrey, Megan Bernatchez, Jeffrey, who will be assisting instructors and TAs in helping to troubleshoot the technology in the classroom, and they're available for one-on-one as well as sort of drop-in sessions. The recording of the presentations and classes, though, is not meaning that students are not going to be attending class in person or synchronously if classes are remote. And I think it's really important to make that clear at the start of the quarter to your students, that these recordings are to provide flexibility for those students who can't attend synchronously due to being ill or having some travel or visa issue that's related to COVID. So instructors should be making it very clear if their expectation is that students either attend synchronously remotely or attend class in person, that that is the expectation, and that can be included in the syllabus, as well as expectations around late assignments. We learned from last quarter that needs to be really spelled out, because otherwise it ends up kind of being a little bit of a slippery slope as to what is a COVID-related reason or another legitimate reason versus something else. So at the very start of class, we strongly recommend that. As Hilary said, please do familiarize yourselves, both instructors and students, with EHS protocols. These are protocols that will notify instructors when a person in their class tests positive. The website, I think the flowchart I put into the chat box earlier, so take a look at that. I also want to note that if a person is positive in the class, a student is positive and the instructor is notified, that currently that does not mean that class goes online, and we'll certainly follow EHS guidance on this front, but currently instructors, students are all masked and the vast majority are vaccinated, and we're not moving classes online when one of these notifications occurs. So we realize it's a lot for instructors, winter quarter, especially with the last minute changes from expected in-person now to remote. So Hilary and I, we will be holding a check-in session at the same time next week. So that's January 12th, 3 to 4 p.m. It'll be for all winter quarter instructors. Other student academic services staff are welcome, as well as program directors welcome to attend as well. We want to hear how things are going. There'll be time for questions and any sort of additional updates. The other session that we'll be offering at the school level is a workshop on accessing resources for your students for mental health and counseling. That will be on January 20th, 11 a.m. And again, it's targeting the winter quarter instructors and student academic services staff, because we realize this has been a really trying time for students, and we're seeing an uptick in need for mental health and counseling. And it's often the instructor who's on the front line for helping students access that. So hopefully you'll be able to attend these 2 sessions. And thank you. Thank you all for teaching. Thanks for your commitment to supporting students. And please do ask questions if there are further questions.
Thank you so much. So we have about 13 questions so far. The first one, I honestly don't know the answer to, so I'm going to read it. But if one of you knows the answer to it, let me know. If not, we'll try and get back to Susan separately. This was a question saying, I have 2 colleagues from Denmark that would like to visit my clinical research program in May or June for 4 to 6 weeks. Are visits like these currently being approved by SPH UW Medicine /UW? Anyone know? If not, we can get back to Susan individually. All right, we'll get back to Susan individually. Okay, next question is from Mary Ann. Yeah, so Mary Ann, really good, yeah, good question about how confident are we that the precautions that we've been using to limit transmission in the classroom will be enough. So, and you give the great analogy to measles. So one thing that's different is that we are all wearing masks in addition to being vaccinated. So that's different. Normally when we have measles transmission, people aren't wearing masks by, across the entire community, whereas they are here. We are pretty confident at this point that we would, that people should be upping their game in terms of mask wearing. So Tim alluded to this, and I put the link in earlier in the chat box to this really great piece that EH&S has done about leveling up your mask. So I think what you'll see over the coming weeks, Marianne and others, is really this push towards shifting away from just using a cloth mask to using a surgical mask and to using it correctly. And there's really good guidance in that leveling up your face mask, including a link to a great CDC video about how to improve the effectiveness of a standard surgical face mask, and the idea of doubling up that surgical face mask with a cloth face mask. But also, I think you're going to see a lot of push to encourage people, not require, but encourage people to shift towards using, for instance, KN95s or KF94s in situations where they are exposed to large numbers of people for significant periods of time. So we don't, of course, we don't know absolutely that that is the case, but we have really good data from last quarter showing that the measures that we took were really effective. So we will continue to monitor it carefully. One thing that's great about the contact tracing that we have is they automatically know if we have more than one person in a particular class who test positive. We literally saw no cases of classroom-based transmission in the entire university last quarter. So we don't know for sure that that's going to maintain with Omicron, but we're encouraging people to really up their game in terms of masking and continue following, all the good procedures that you've been following to date.
Yeah, Hilary, I might just add,
Go ahead,
our experience in the healthcare system is that most of the exposures that we're seeing in our positive employees are happening in the community. They're not happening within the work environment or where they're really wearing that mask. We've had some issues sometimes in break rooms where people take their masks off and are eating together. But it's really the community exposure or that gathering, even small numbers, where we've seen that greater risk as opposed to within the work or classroom environment to date anyway.
Yeah, thank you, Tim. So, and really, UW Medicine has been an inspiration for us in terms of seeing how well they've been doing in terms of really limiting workplace transmission and us modeling our protocols for the rest of campus upon what they're doing over there. So, yeah. Really important, but we are being vigilant and keeping an eye on everything, and definitely encourage you to, to where possible, increase the protection level of the mask that you're using. Okay, question from Chuck, who asked whether or not if an instructor feels that they need to switch to totally online instruction, whether they have to have their course designated as DL. So the official university policy is that if it's 100% online instruction for the entire quarter, the course needs to be designated DL. And that DL designation either needs to go through the standard process through your curriculum committee for the department and then go its way up through the university. That's for a permanent change. For a 1 quarter change, deans have discretion to authorize in individual circumstances where, for instance, if the instructor is immunocompromised, we also do it if the instructor is living with someone who's immunocompromised in the school public health. That's our policy. So if you are going to 100% for the whole quarter shift to DL, yeah, we do need that designation. But short of that, there's an incredible amount of flexibility that we give to instructors. And I want to be super clear that this is a very different place than we were at the beginning of fall quarter when we were saying, we want you to be in person. I would say right now, the default campus mode of instruction starting next week is in person. We are giving considerable flexibility to individual instructors to make a call based upon what works for their class pedagogically while we're in this peak transmission period. So if you have questions, reach out to definitely your department chairs, but feel free to reach out to Carrie and myself as well. But like I said, you don't need permission from us at the OD within SPH. You just go and talk with your department chair. Okay, this may be one for Tim or for Anna. Someone asked, has revising the definition of a close contact been considered? They say 15 minutes within 6 feet is extremely inadequate when considering an airborne virus. I have not heard about any thoughts about revising that. I don't know if you guys have.
I haven't heard anything specific, but I think they're making a good point. There's nothing magical between 13 minutes versus 17 minutes. And so, when we see employees who may have been exposed, we ask them kind of more details around what was that exposure? What were they doing with the individual? Were they masked? Did they, in the healthcare setting, did they have eye protection, et cetera? And so there are a lot of other factors in there, but I think you're making a really good point that could you get exposure given the transmissibility of this less than 15 minutes? Certainly. I don't think that there's anything magical about the 15.
Mm-hmm. Maybe I'll just add in the classroom setting, because people are masked and vaccinated, that does not count as an exposure. So if there's a positive person in the classroom, they don't try to identify those students who are sitting around the student who tested positive. They will, of course, know if other students in that class are positive, and that might raise some alarms, but it hasn't, as Hilary said, no classroom transmission up to this point.
Yeah, I think that's a really important point, Carrie, that I think that definition of close contact, but Tim, you could correct me if I'm wrong, is being unmasked for that period of time in that distance?
Yeah, and so thank you. So if you're wearing appropriate PPE for the right setting, then we would not consider that an exposure. So it's time plus what you were doing and what you were wearing.
Yeah. Okay, next question. So from someone saying, why are other universities around Seattle and other parts of our country committing to virtual learning until the end of January, even the beginning of February, when UW does just 1 week. Although Omicron might be less severe, why shouldn't UW prioritize proactive guidance and wait until cases begin to decrease instead of taking the risk of seeing another surge with in-person instruction? So again, while there are some institutions that are being more conservative than we are, other area institutions like WSU are doing exactly the same thing that we are. And President Kelsey and Provost Richards are in close contact with both those university presidents and provosts, and also with presidents and provosts across the Pac-12. There is just such a huge amount of variability from institution to institution in terms of the percent of individuals who are vaccinated, the amount of testing that they're doing, the amount of masking compliance that they get, their ability to handle online instruction, and honestly, their commitment in some cases to equity. For us, the commitment to in-person instruction really comes down to making sure that those students who have not fared well under remote instruction are getting access to the best possible instruction that we can provide safely. And our confidence that our community has done really well over the last quarter with that. That being said, we understand that doesn't work for everybody. Not every class is set up well to do hybrid, and we know they're going to be people remote. You may have a particular class, my class that I'm teaching, the vast majority of my students did not want to come back in person next week. And so we're going to continue remote next week. And all the instructors have the flexibility and discretion to figure out what works best for them in terms of instruction for their students, and other considerations that you're grappling with for the next couple of weeks while we're in this difficult position. So that's just where we landed as an institution. Thank you to Anna for your comprehensive presentation. Question: what is the best resources for determining your risk profile in the current moment?
Yeah, thank you, Susan. I wasn't sure what that means.
So every once in a while I'll see there's websites where people will cite, I went online and my risk profile is XYZ. Which a little kooky to me, but but Susan's fantastic, and so I'm thinking she knows some.
And Susan knows how to get in touch with me, so I'm happy to talk to her more about it. But yeah. I think what's important is to differentiate the risk of exposure from risk of severe disease, right? Because those are really two very different concepts. So I also think that we would weigh those two differently.
Okay, we'll let Susan reach out to you individually. I just talked about the decision about going back in person next week versus waiting one more week. The vaccination campaign, and this is from another person, the vaccination campaign and masking have not prevented the spread. How can UW Public Health lead the way on more innovative way forward? Well, so the vaccination, it depends upon what you mean by vaccination campaign and masking. So within the University of Washington community, our effort to get the vast majority, and it's over 97% of our faculty, staff, and students fully vaccinated. Now we're starting to push towards getting them boosted. And the really, really high adherence to masking within the UW community has meant that we have had very, very little on-campus transmission. As Tim pointed out, the exceptions are, we've seen cases where people carpool together, or they've been eating together without their masks on in a break room, things like that. But we have been hugely successful at the UW. What we are not able to contain is community-based transmission, because honestly, I don't wear a mask around my family, and they may not have the same behavior constraints that we do at UW. So I actually do think we've been very successful. The question of what do we do with the larger community to maintain, get us to a better place. I don't know, Anna, if you want to comment on what are your thoughts as an infectious disease doc of what as a society can we do better?
I think there's so much misinformation about the vaccines. And I do think that it would make a difference if our vaccination rates were not 80%, but 100%. Right? It would have been different if they were 100% several months ago. Right? We would have been in a different place prepared for this new variant. So I think the fact that even there's a small proportion of people who are not vaccinated is problematic. And of course, there are people who are immunocompromised. We talked about them, and they're not able to respond to vaccines, and we have a responsibility to protect them.
I think it also goes back to what's the goal of vaccination, right? And in many respects, it's not necessarily to prevent infection. That would be great, but it's more important that we prevent severe disease. We prevent the number of individuals who actually need to be hospitalized or death. And we're seeing this disconnect, all right? The death rate is not going up. Now, sometimes that lags, and so that may still, but it's not going to go up the same degree relative to the number of infections. And that's an important role of vaccination. And I think it would have been great to have been 100% vaccinated in our community. At the same time, I think about, gosh, what if we were 60%, as many parts of the country are, as opposed to 85%, it could be even worse. And so I think, and then I think back to influenza vaccine, right? Influenza vaccine on a good year is 60% effective in preventing infection, but it does decrease severe disease and death. And so I think those are the important components of this. We're just getting overwhelmed by the sheer volume of infections, even be it more mild. But it could be a heck of a lot worse if we had the same degree of severity as what we saw in previous surges.
So I'm seeing a lot of questions from people about whether or not we're going to be providing because we provided cloth face masks early on in the pandemic, whether or not we'd be providing non-cloth face masks. And that's a question that we've been discussing a lot across campus. One of the reasons we were able to provide cloth face masks to everyone was because they're reusable, which meant that we didn't have to provide them on a regular basis to individuals. It was a one-time thing, and we were able to order them, get them out. We are making sure that the campus storefront is better stocked with surgical masks and with KN95s and KF94 masks so that units can purchase those. I don't think that we will ever be in a position, just in terms of the volume of masks that would be required, because even if in theory, there's single-use masks, but even if you reuse them, you don't use them for, like, I have cloth face masks that I've had for the last 2 years, right, that I just keep washing. So we just don't have the capacity as an institution to have that kind of throughput of masks, of disposable masks for individuals across campus. However, we will have them available for units to purchase. So obviously for clinical settings, there's stricter guidance for that. Some people asked, I think, which is really the most important question, which is, what about those people who cannot afford to get them themselves? So a lot of the issues that we saw early on in the pandemic of lack of availability is no longer the case on the general market. So in general, we're seeing good availability for surgical face masks and the KN95s and KF94s through general market sources. And so if you are able to purchase those on your own, I definitely would recommend that you do that. If financially you are not able to do that, I think we have the capacity as an institution to provide some of those masks for those individuals who are experiencing financial distress and need access to them, but not to be able to give them to everyone across the institution. We are at time. I'm looking quickly to see if, so I saw also a couple of questions about what's going to happen after. So we had said that staff should didn't need to have a telework agreement in place could stay home for the first 2 weeks. We will reassess that situation. And I think similarly, the university leadership is reassessing on a day-to-day basis what, whether or not there's a need to add to that period of time or to have different shifts. So I think to me, it really depends upon where we are in terms of the Omicron peak. But if we're in a similar place to where we are today, I think you could reasonably expect that we would extend that period. So I think that, the take home messages at this point are there's a lot in flux. Please stay tuned and keep track of what the guidance is from the general campus, both in terms of instruction, but also in terms of boosters, in terms of mask wearing, in terms of quarantine and isolation, all of those different kinds of things. And please continue to do what you've been doing all along, which is to take good care of yourselves and others by adhering to good infection control practices. As Anna said, if you're eligible for booster, please get one. May not be required yet, but it seems hard to imagine that it won't be required at some point, and it will help to protect you against severe disease. And continue to be patient with yourselves and with others and extend grace to each other during this difficult time. I'm fairly confident that we're going to be in a better place a month from now than we are today, but I'm also pretty confident that the next couple of weeks are going to be pretty rocky. So we've tried to provide as much flexibility as we can. Please take advantage of that and take care of yourselves. And huge thanks to Tim and Anna and Carrie for being our panelists today.
Thank you.
Yeah, thanks everyone.
Thank you.